Good. Hi, everyone. Welcome to this TRIC webinar about our next national project, TRIC Block. I'll just give a little bit of an introduction before we start, and also give people a bit of time to file in over the next few minutes. I guess first thing to say is that thank you for joining. We've had over 130 people register for this webinar, which I think is fantastic, and I think is an amazing reflection of where we're at with trainee-led and delivered research nationally, which I think's fantastic. Rich is our lead for TRIC Block, which is our next national project. Rich was successful at the ICS State of the Art last year with an absolutely fantastic presentation, and I think you'll agree what is a really interesting and promising project. You could be next. So again, State of the Art this coming year. Everyone who is shortlisted will present, and that'll be the project for the following year. We're really pleased. TRIC Block is a collaboration between us as TRIC, but also the ICS, FICM, and PICSTAR. So we have paediatric involvement for the first time of one of the TRIC projects, which I think is really exciting. We've had lots of interest in site sign up. We've got well over 100 sites, probably close to 150 sites signing up, and people are working hard on getting their audit approvals and starting their site setup. So that's me waffling and has wasted a few minutes to let people join in. Without further ado, I'll hand over to Rich, who's our project lead, who's going to give us a presentation about TRIC Block, and what the project involves, what the background of it is, and what you all guys need to be doing as site leads and data collectors. And then we'll also spend a bit of time looking at the REDCap and the data collection service. And then the other thing to say is that there should be a Q&A. So you should be able to write questions in the Q&A. Please do that through the presentation. I'll be looking at those, and then myself, Rich, or anyone else on the TRIC committee will then be able to answer those as we work our way through. I can see your screen, Richard, so that's always a good start. So the sharing is working.
Great, yeah, thank you, Adam. All good. You can hear me okay as well. Excellent.
Yep.
Brilliant. Okay, so yeah, just to echo what Adam was saying, thank you so much for joining, everyone, and thank you so much for all the interest in the projects that we've so far. So in the next sort of half an hour or so, I'm going to take you through the background to the project, the aims, the methods for the project, the structure that it's going to take, how we're going to go about collecting the data, any timelines that we need to follow and where we're up to. And then we're going to do a bit of an overview of REDCap, which is essentially the research data server that we're going to use to collect our data for this project. So again, just to say thank you so much to those that have signed up so far. So I think as of this morning, we had 128 adult sites which have joined and 20 paediatric sites. And we're hoping to get any more that can come along in the next few days. Again, as Adam said, a number of people have sort of interest in societies and bodies who've got interest in the project. So we're pleased to have the support of the Faculty of Intensive Care Medicine, Intensive Care Society, and then obviously TRIC. And then we're pleased this year that PICSTAR, so the Paediatric Intensive Care Trainee Research Network, have also joined us. So that's brilliant. So if we move on to think about the background to this project and why I think it's important. So the inspiration came from my own experience as a trainee rotating around the region in Manchester and the Northwest, and seeing continuous neuromuscular blockade used for a range of indications, but often done differently in different sites. When I did a bit of reading into the background of this, you can see that yes, we do use continuous neuromuscular blockade for a range of indications, but the evidence base for that is somewhat limited. Here we can see sort of a range of indications for which we might use neuromuscular blockers in general. And if we take airway off to one side, because that's bolus dosing and very different, the other indications there are those for which we might use continuous infusions of neuromuscular blocking drugs. But of these, it's only really moderate to severe ARDS and to some extent traumatic brain injury for which we have, decent evidence and recommendations for. These are sort of a mixture of consensus guidelines from 2016, 2020, and then also from 2022, which were, groups of people have sat down and looked at all the evidence available. But actually, even from this, no one's been able to offer anything more than a weak recommendation for the use of continuous neuromuscular blockade in moderate to severe ARDS, and been unable to recommend the use of it for any other indication, although obviously we do that. There's also this, what we call the rise of rocuronium. So during the COVID-19 pandemic, there was, due to a shortage of cisatracurium, there was a sort of a rapid practice update and some guidelines issued, which said that in the absence of a supply of cisatracurium, that we could use rocuronium instead. Now, it's important to note that the clinical trials and the RCTs which did support the use of neuromuscular blockers in ARDS only studied cisatracurium. So actually, we've never tested rocuronium in an RCT. And obviously, anecdotally, it seems to work, but that's not been tested in research. We know with all continuous neuromuscular blockade, and it has been shown that there's a risk of harm with prolonged use. And also, we're concerned about potential prolonged paralysis long after we turn it off, particularly for patients who receive it for a long amount of time. This could potentially be more of an issue with rocuronium as well, because of its organ-dependent metabolism. So patients, like often our patients do, particularly in adults, have impaired renal or liver function. That could lead to a longer paralysis than we're hoping for. From my own experience, and I think from what's been written in the literature as well, there seems to be inconsistent monitoring practice in terms of monitoring our degree of neuromuscular blockade. And the same goes for sedation as well. I've seen some places using kind of EEG-derived monitoring methods, such as BIS, but some places not. So we put all of this together, I think nationally, we suspect that there's going to be significant practice variation in what we're doing. And that's what's led to wanting to do TRIC BLOCK, to try and quantify and try and establish what our national practice variation is at the moment in adults and in paediatrics. This has led on to the aims of the project. So the main aim is to evaluate current practice of prescribing, maintenance, monitoring and cessation of neuromuscular blocking drugs by continuous infusion in critically ill patients in UK and adult paediatric ICUs. And as I've said, the main aim is to try and quantify our practice variation. And what this represents really is a first step in working towards future comparative effectiveness trials, potentially, or looking towards building national guidance. Also importantly, this is feasible and it's deliverable by a trainee network through working with our own DT colleagues. So it seems like a sensible thing for us to study. What we're going to do, so as I've sort of alluded to already, the design will be a prospective multi-centre service evaluation. Our aim will be to evaluate our current practice. The population will be all patients commenced on invasive mechanical ventilation within a 2-week screening window, which you as your site can choose. And I'll come on to the specifics of that in a bit. There won't be an intervention, and the duration, as I said, will be 2 weeks screening window, where each included patient will be followed up for 7 days. So the specific inclusion criteria are all patients who are newly admitted and commenced on invasive mechanical ventilation during your 2-week study period will be included. This does include patients who are intubated prior to admission to ICU, so such as patients admitted in ED, so intubated in ED or pre-hospitally or in theatre, and then come to ICU, providing they were intubated within 24 hours. So if they're intubated more than 24 hours ago, or they've come from another hospital where they were intubated more than 24 hours ago, they're not included. So we can see on the flow diagram on the right, so all patients admitted and commenced on invasive ventilation during the study period. we're going to divide that into 3 subgroups. So the first is acute hypoxemic respiratory failure, which includes ARDS. The second is traumatic brain injury. And then the third group would be just all other patients. If there's any use of continuous neuromuscular blockade for greater than 1 hour in any of these groups, then those patients will have the full data collection performed. And if not, then we'd only collect sort of basic data on what happens to those patients. The reason for those 3 subgroups is because of what we were saying about there being some evidence for acute hypoxemic respiratory failure and traumatic brain injury, and not for the other group. So what data are we actually going to specifically collect? So we're going to look at, by sort of assessing what everyone submits nationally, the prevalence of continuous intravenous neuromuscular blockade for invasively ventilated patients. We're going to look at which agents are used and for what indication. We're going to look at the dosing and the duration of use, both overall and also then in the context of patients' BMI, lean body weight, renal and liver function. We're going to look at the use of bolus dosing before and during continuous infusion where possible. We're going to look at whether there's any assessment or monitoring for depth of neuromuscular blockade, and the same for sedation as well. We're going to look at how neuromuscular blocking drugs were discontinued if we get to that, and also if any emergency reversal agents are needed at any point. And then finally, we're going to look at sort of adverse events and incidents which might occur associated with continuous neuromuscular blocking drug use. So the project overall is structured, sort of has 3 arms, 2 of which are quite minor. So the first one is we're going to ask all the site leads to share their local guidelines or policies regarding the administration of continuous neuromuscular blocking drugs if you have them. Now, these might well be buried on the intranet somewhere. You might need to ask pharmacy colleagues. They might be buried inside a protocol for neuromuscular blocking drugs in general. It'd be really helpful if you can have a look and dig around to see if you do have any policies and then share them with us via the link which we've included in the site leads instructions document. And that allows us just to see, what's being recommended nationally currently. The second bit is that just once per site, we're going to ask the site leads to complete a site level survey, and that'll be a short Google form which we'll email out to you. That's going to ask very basic questions about whether you're a DGH, whether you're a teaching hospital, and what specialties your hospital manages. And again, that's just to try and allow us to build a picture and set the data into context. And then the third thing is obviously the service evaluation, the main TRIC block study. This is kind of how the organizational structure is going to work. So kind of collaborators. So this is anyone who's going to be able to assist with data collection. We do encourage sort of NDT involvement in this, so including pharmacists, ACCPs, AHPs. And then we've got our local site leads. And thank you so much to those of you that have joined as site leads so far. So you guys have got the bulk of the work at the minute involving just registering your study with your local audit department and getting approval there. Coordinating local data collection. You might be asked to answer queries locally. You'll need to complete the unit level questionnaire that I've just talked about, as well as share any local guidelines if you have them. We've then got our regional leads. And again, thank you very much. They've done a brilliant job at helping coordinate site recruitment regionally. And then, of course, we've got the TRIC block national group, who were basically trying to coordinate things nationally, deal with keeping the study design, and also answering any site queries. So looking at the next steps. So if you've not already, please read the protocol. It's a very thorough document which details exactly what we're doing, why we're doing it, and the evidence base behind why we want to do what we're doing. If anyone doesn't have access to the protocol and needs the protocol, please ask your site lead to share it with you, or you can email the TRIC block email address. The next step and the most important thing at the moment is to get approval from your local audit or clinical governance team. Once you've done that, we're going to establish a team at your site, so find your collaborators. And once you share your audit or clinical governance approval with us, then we can return a Google form to you, which asks you for the details of your collaborators so that we can issue them with REDCap access. And REDCap is the data collection server that we're going to use. It's really important that anyone who's going to collaborate with you, you put their details on that REDCap form, because that's also how we're going to acknowledge anyone who's contributed to the project in future publications. You need to select your screening window, which we'll come on to in a second, and then obviously move on to collecting the data. So data collection. So each site will need to choose a 2-week or a 14-day screening window. And we've left this up to you, but it can begin at any time between the 2nd and the 22nd of March. So you've got a 3-week period there, and you don't have to start on a Monday. You can start on any day within that 21-day period. And from that point then, for 14 days, you're going to monitor all patients on your unit, and any who meet the inclusion criteria would then be included into the study. Once a patient meets the inclusion criteria, you would record their kind of initial details onto REDCap, and I'm going to go through that in a minute. And then you would follow each patient for 7 days before completing the remaining data fields and outcome on REDCap as well. So the best way to keep track of that, and this is what we're going to share with site leads, is with a screening log. So this will be a sort of a document which you can use. So you can put your date at the top and your start and your end date of a 2-week screening period. It's got the inclusion criteria on there again, just for a reminder. It's also got a definition of day 1. So once you include a patient, once they meet the inclusion criteria, that's going to be day 1. So day 1 is either going to be the day that the patient was intubated in your ICU, or it's going to be the day that the patient arrived intubated, providing they've been intubated within the last 24 hours. On the form here, you can put the REDCap ID, and that's an ID, a unique ID, which REDCap will give you. You can put the patient's name, their hospital number, the day 1 and the day 7 date to help you keep track. And then also you can tick when you've done the final outcome form on REDCap. What's really, really important is that this document doesn't get shared outside your organisation under any circumstances. So, and particularly don't share it with the TRIC BLOCK team. This form obviously allows you to identify the patients that you've got in your cohort, but the data submitted onto REDCap and to us must be anonymous. So we're not. So it's really important. And then at the end of your data collection period, it's really important that you destroy this, kind of obviously delete it or put it in clinical waste if you've printed it off, in confidential waste. So what if I'm not sure of something? So first, speak to your site leads or your other local data collaborators. They might be able to help. Also, the protocols are a really good source of information. We're going to do a frequently asked questions page and a REDCap user guide, which we'll put on the TRIC website. And also this webinar has been recorded, so if you ever need to return to anything, you can. And of course, you can also email the TRIC national team, which is tricblock@gmail.com. And then I guess if you do have any safety concerns about anything that you've seen, please discuss it with the responsible consultant for the patient. Another important thing to cover is, do I need consent? So patient consent, so no, this is a service evaluation, it's not research. All the data collaborators are part of the regular MDT. There's no one external reviewing your patient data. And also the only demographics that we're going to collect are sex, age bracket, height and weight. So nothing that we could use to identify a patient. We're not sharing any identifiable data nationally, and the TRIC BLOCK team will never have any way of identifying a patient from the data you submit to us. It is important, as we've said, that you must have permission from your local audit department and a named consultant. And also your site might ask you to go through clinical governance or Caldecott approval, and if they do, then that's fine, just follow that process. You might have heard of the national data opt-out. That doesn't apply to non-identifiable anonymous data, which is what we're dealing with here. So why get involved? So hopefully, well, obviously if you're here, you're involved already, but if you're trying to drum up support from anywhere else, hopefully in the long run through doing this, we're going to improve patient care. For yourselves, the data collection is easy and it will fulfill annual appraisal or ARCP requirements. It's really great to be involved in a national trainee-led network project. And also, as we've said, anyone who does collaborate and anyone who has a REDCap login will be then named as a collaborator in any future publications. So the timeline, so the deadline for returning your audit approval to us is the 23rd of February. So you've got a couple of weeks to go still. So if you've not put that in already, I'd really encourage you to do that as soon as you can. And then, obviously send polite reminders whenever necessary and try and get it into us by that deadline. As I've said, once you've sent us your audit approval, we'll then give you the details so you can create your REDCap logins for your collaborators. Each collaborator will need an authenticator app. That's because REDCap has two-factor authentication. So you'll either need Google or Microsoft Authenticator on your phone to be able to log it. And then your data collection, your 2-week screening window can start at any time between the 2nd and the 22nd of March. So that means that if you start on the 22nd of March, the last date that a patient could be included would be the 4th of April. And 7 days after that would be the 10th of April. So by the 10th of April, everyone should have all their data in. And that will be it. So now I'm going to move on to REDCap. And I'm going to do a bit of a demonstration of how that works. So our REDCap is being hosted by the University of Warwick. And this is a secure environment, which is going to allow us to store the data you send to us securely. So I'll just swap screens. Just check you can see that. Great. So when you log into REDCap, you will get a screen which looks a bit like this. You will only see one project. So I'm just going to click on this for now. And then you'll get a screen like this, which is quite busy. But all you need to do is click on the Add or Edit Records button. This will bring up this screen, which allows you to add a new record. And what you'll see here is ID. So this is number 5, because this is the 5th kind of practice patient that I've done. The ID that you actually get will probably be quite a lot longer than that. But that's what you need to put on your screening log to keep track of this patient. And then here there'll be a list of forms that you need to complete. So initially there's just one form. And so you click on this grey button here to open it up. The first question just asks you whether the patient meets the study inclusion criteria. And there's a reminder there of those if you need them. Then the next thing is this, what I've called a date calculator. So when you go through the form, at some point it might ask you what happened on day 3 or what happened on day 5. And if you're anything like me, sometimes that kind of confuses me a bit. So if you click on here, you can download a little small document which opens in your web browser. And it looks like this. So it's a 7-date calculator. So you can put in what is your day 1 for your patient and then click calculate. And it just gives you what days 1 to 7 are. And it might be helpful just to have that at the side if you think it will help you, just so you can jog your memory of which date's which. This form doesn't send any data to us. It doesn't send, there's nothing saved anywhere. It's just to help you if you need. So going back to this, then we choose whether our patient's in an adult or a pediatric intensive care unit. The data fields are almost the same for both adults and peds, just with obviously some differences in terms of illness severity scores and using PARDS rather than ARDS. And then once we've done the form, it's important that we mark it as complete. So you do that then, and then you click save and go to next form. If you don't mark it as complete, it won't allow you to carry on. The second form here is some patient admission details. So we're going to just work our way through. There's a few fields talking about whether it's elective or emergency, what the time for an admission to intubation was. And if they're intubated before coming to ICU, you can enter a negative number. So this is in hours. So I could put -5 there. But again, there's lots of examples there just to make sure you understand which one you're doing for your patient. It'll ask us where our patient was intubated. So it might have been intubated in ED. And it'll ask us if the patient underwent surgery before this admission to intensive care. If we say yes, there's a couple of questions. If you say no, we just move on. There are some baseline demographics about our patient. So it's got all age ranges in brackets. It asks us about their sex, their height, whether it's actual or estimated. And it will calculate our BMI and lean body weight for us. Obviously, if they're female of the right age, it will ask us whether they're pregnant or not. And again, we're going to click complete at the end of the form. And save and go to next. The next page is going to ask us what sort of an illness severity score, just to allow us to capture how sick the population is. So for adults, it's SOFA score, and for pediatrics, it's PIM3. And this is set up exactly as it would be if you were if you were to calculate the score on MedCalc yourself. Obviously, I'd fill in the form, but just for the purposes of not keeping you too long, I'm just going to click complete and move on here. And then importantly, it's going to ask us what the indication for invasive ventilation was. And this is to depict which subgroup the patient is in. So I'm going to choose acute hypoxia respiratory failure. And what this is essentially saying that this is as far as you're going to get within the first 24 hours of the patient being with you. So at this point, you can click complete, and then you would save and exit. And this is where it would hold until you get to the end, until you get to day 7 for your patient, at which point you can go back in and complete the rest of the data. So if I was to go out and log back in, I would go on, and I was to open up TRIC BLOCK again. I could go on record status dashboard. And here I can see number 5, which is the patient I've just been working on. And you can see that I've completed the first 4 forms for the patient. And then here is the next form to complete. So this is what I'd go back into at day 7. So subgroup details. So we know this patient's in the respiratory failure subgroup. It's going to ask us what we think the most likely cause of that was, whether they received ECMO. And it's going to ask us to calculate the PF ratio. All you have to do is put the 2 values in and it'll calculate it for you. And then on the basis of that, we're going to decide whether the patient had ARDS or not within the 7 days that we were following them up. And then I guess the most important question is it's going to ask us whether we use continuous neuromuscular blocking drugs in this patient. And the cutoff is whether they were used for greater than an hour. And the reason for that is that I guess if it's less than an hour, it could be similar to a bolus dose. So we're going to say yes for this patient. Again, I wouldn't normally mark it as complete unless I've done all the fields, but just for the purposes of this, I'm going to say complete and continue. So now it's going to ask us about the data about what we actually did with the neuromuscular blockade. So we're going to choose our primary reason. So for this patient, we'd say refractory hypoxemia. It's going to ask us which drug we use. So say we said ROC. It's going to ask us the strength that it's made up in milligrams per mil. And it's going to ask us about the rate that we started it at. And the reason we've got the option for units, so mils per hour, and then also obviously mics per kilo per hour, or another unit, depending on where you're working and how you dose this. And then it'll ask us a couple more questions about whether we increased or decreased the dose, whether the patient had a second agent or an alternative agent, and why that was. The thing we need to do next is look at our daily infusion charts and see in the 7 days that the patient was being followed up for, how many discrete episodes of continuous neuromuscular blockade did they have? So what we've said is if it was stopped for greater than an hour and then restarted, that would count as a discrete episode. So say the patient had neuromuscular blockade for a day, we paused it for a couple of hours, and then they needed to go back on it, I'd call that 2 episodes. And hopefully, again, through looking at the nursing charts and just adding up every hour in which we gave neuromuscular blockade, we'd be able to calculate how many hours the patient received that for. So 26 could be reasonable. It'll also ask us whether we saw that bolus doses were given, and were they given sort of prior to, during, or not, or both, or neither. Obviously, we're just going to do this from the best of our ability. So if we're looking at the
please go get
the clinical notes and also the nursing charts. So this patient might have had a bolus of ROC prior to infusion. And was the bolus prescribed? So it might have been prescribed, it might not have been. We'll see what we can see from looking at the charts. It's going to ask us whether we adjusted the dose for any of these factors, so BMI, lean body weight, renal function, liver function. And we're going to ask a couple of questions about whether we're using a nerve stimulator to monitor the level of blockade and whether we acted on that, and how we're monitoring sedation, whether we were just using our clinical assessment, whether we're using an EEG or any of the scales that we use in adults or peds. And then the last the last bits is, so we want to know how much sedation these patients are getting. So we're going to be asked at a couple of time points. So the first time point is we want to know what sedation was the patient receiving 2 hours after we first started continuous neuromuscular blockade. So if we started our ROC or assisted coronary infusion at 2 p.m, at 4 p.m, we want to know what sedation was running. And all you have to do is just tick which ones were running at the time. So it could be propofol, midaz, and remifentanil. And then it's going to ask us, on which days of their 7-day follow-up did the patient get continuous neuromuscular blockade? And that's where our 7-day date calculator might help jog our memory. So we could say maybe our patient got it on day 1 and day 2. For the following days, it's going to ask us at midday what sedation was running. And it's the same as before, just a tick box. And also whether the continuous neuromuscular blocking infusion was running at midday. We're going to do that for each of the days that the patient received it for, just the same couple of tick boxes. Nearly at the end, we're going to look at how our neuromuscular blocker was discontinued, if it was. So was it weaned or an abrupt stop? And also whether we had to use an emergency Sigamadex or reversal at any time. We're going to look at whether there was any adverse events or incidents, such as things like allergy or extravasation, or whether there was any unintended line or device removal. And once we've filled all that in and we're happy we've entered every data field, or as much as we're able to, we're going to tick complete and save and go to next. This is the very last form. And there's only one question on this form. Now this question won't appear unless you've marked all the other previous forms as complete. But once you have it, it'll be there, and all we have to say is what happened to the patient at the end of their 7-day follow-up period. Once we do that, we'd also mark that as complete and then save and exit. And we can see that we've now filled in all the data for that patient. If we go back to our record dashboard, we can see that for patient number 5, we've completed every form apart from this one, and that's only for patients who did not receive continuous neuromuscular blocking drugs. So I think I'm going to stop the overview there, because if the patient didn't receive continuous neuromuscular blockers, it's much less involved, the data collection. And if it was a pediatric patient, it's the same, except for it's the PIM3 score instead of SOFA, and it's PARDS instead of ARDS if the patient had ARDS. So I'll stop sharing my screen there, and I might go back to Adam and see if there's anything from the Q&A, and we'll try and answer any questions that you've got.
Thanks very much, Rich. That was great. Obviously, I know the study, but I think that was very thorough and answered quite a lot. There are some questions in the Q&A. A couple of them I fielded, and a couple of them I'm going to defer to you. So just to run through them, there was first question. There's a question about, is the data collection prospective, i.e. if they come into work on Monday morning and the patient was intubated on Saturday, should we still include them? My sense on that is that you should, providing that patient was commenced on mechanical ventilation within the site selected 2-week period.
That's right.
And you're nodding, which is encouraging for me. There was another one around patients who are intubated for low GCS, should they be included, i.e. patients intubated for something that wasn't rest failure or TBI? And again, I think those patients should be included. All patients commenced on invasive mechanical ventilation during the study period should be included. And we'll capture those indications in the REDCap. I've got a tougher question, which I'm going to defer to you, Rich, which is asked by Stephen Webb, which is patients transferred from another location, i.e. another hospital, who have been invasively ventilated for more than 24 hours prior to ICU admission and will be excluded. And the question is, why is this an exclusion? This could exclude some patients, particularly those at SARF or ECMO centres. And I know this is something that you will have thought about very carefully during your design of the study. But yeah, I'm going to give you a tough one.
The reason for that is because we're trying to make sure that we're capturing patients in the acute phase of their illness, and what we don't want is what we felt wouldn't be best is to start including transfers from greater than 24 hours ago. So I hope, I guess, if someone crashes onto ECMO and gets transferred in, then hopefully the ECMO centre they land at will be collecting data. But obviously appreciate that if it's been longer than 24 hours before that happens, then that patient won't be included. But we had to draw a line somewhere, so we're just going to try and focus on like the hyperacute phase of illness.
Awesome. Right, I'm just reading through. They're all flying in now. Good. So next question is, I work on a cardiac ICU which functions like an extended recovery. Most of our patients are admitted, intubated and ventilated after elective cardiac surgery, then extubated after about an hour, 2 hours on ITU. Do you still want to include those patients? It's the cardiac surgery question.
Yeah, so for those patients, I should have said, or should have highlighted, so there's almost no data collection, so we don't do the SOFA score for those patients or the PIM3 score. So basically, when there's that question that says, did the patient have surgery? If you tick yes, then it says, were they extubated within 24 hours of elective operation? You tick yes, then that's it, that's done. So yeah, they would be included, but there's almost no data.
Cool. The question here, we have 4 ICUs on our site. Would you recommend separate site lead for each ICU? So this is a common thing that's happened across the TRIC projects. To be honest with you, it depends on your local hospital and a bit of local knowledge about your hospital and your sites. So some hospitals will be set up where, okay, they're separate ICUs, but they're very close to each other physically, whereas others will be quite separate. We're generally pragmatic, and we can be quite flexible depending on what the unit is. Fire us an email. We've probably had experience with that site in the previous projects, and we can usually be quite flexible to make that work. The main thing we want to make sure we're capturing as many patients as possible, and that's ultimately what makes the research generalizable. So if it helps you to capture your patients, then we're usually supportive of that. Just refreshing the Q&A. My hospital's audit application form, the standard being audited needs to be mentioned as a mandatory field. What should I enter? Is there a FICM ICS NICE Association with anaesthetist standard guidance for this? Rich, what do you think?
No, there isn't. I know some sites have put a standard of saying that all continuous neuromuscular blocking infusions are prescribed appropriately. Well, that would be a reasonable thing to ask. So you could put that as a standard if needed. But yeah. I guess if there's an option to say it's a service evaluation, then that's what we should do because that's what it is. But if it can't be explained away like that, then yeah, you could just put a basic standard like that.
Yeah, I think it would also be reasonable to include some ARDS guidelines. That would be some clinical guidelines that are essentially informing the study. So you could include that if you needed, but I think what Rich describes is probably best. PEDS question. We get a lot of PEDS patients coming in with retrieval teams who run neuromuscular blockade infusions for safety in transfer, but we wouldn't continue once they arrive. Would they be included in the blockade arm if infusions stopped after ICU admission? Usually they don't get stopped until over an hour after admission due to time taken to settle, sort out, etc. PEDS transfer.
So I guess it depends if they fall into the inclusion criteria. So if they've been intubated within 24 hours and they come over on a neuromuscular blocking infusion, then they would be included, and you would say that they'd had a continuous infusion. I will think about very carefully about how to make that more, to pick that out in the case report form so you don't have to put mountains of data in. So I will do something about that, Hannah. It is, but it's going to be studied within the PEDS transfer network as well as a separate project later in the year. So those patients will be captured that way if they don't get captured in TRIC block.
Watch this space. Would you consider multiple boluses, e.g. for a transfer to MRI, as included in the blockade subgroup?
No. So if your patient doesn't get a continuous infusion, the minimal questions you do get asked, one of them is, did the patient get boluses? So you could put it in there, but no.
Cool. Any others? I think there's some in the chat. Let me go and have a look across in the chat. Oh, there is. Oh, okay. ARDS criteria. Which PF ratio should we put in during 7 days? Is it the lowest?
Yeah, it'd be the worst PF ratio in the 7 days. But or the PF ratio which allows you to diagnose ARDS. But yeah, it'd be the worst. Yeah.
Worst. Good. That one's been answered. That one's been answered. Difficult to weigh patients in ITU. Can we take approximate weight?
You can, yeah, just take that it's approximated on the form. Yeah.
Yeah. Will the study include patients that are intubated pre-hospital, but on arrival to ED dies within an hour of arrival?
No, because
No.
they wouldn't get up to your unit, so they have to land on the unit to be included. So no, unfortunately not.
Yeah. So in the exclusion criteria, they have to be actually admitted to ICU. Just want to be clear. If the study, sorry if this is repetitive, just want to be clear. If the study starts on Monday, should we include all the patients intubated on the ICU?
No, so I guess,
No.
yeah, that would be a lot of work. So no, just start. So when you start, that's a clean slate. So just anyone who comes in from that point, that's who you include. Yeah.
So it's all new patients, as in all
Yeah.
commenced on ventilation.
Yeah, so you could have a patient who's been on the unit for a few days, but then gets intubated. They would be included, but yeah, not yeah, not everyone who's there at the start who's on a ventilator. Yeah.
Sorry if I missed that. If in the study period, if did not require blockade initial period, however, required infusion afterwards, like after 1 to 7 days, still included in the study for the infusion group. I think the answer to that is yes.
Yeah, they would be, providing they've
Yeah.
been intubated within 24 hours. Yeah.
Yeah. So those patients that are intubated, you then follow up and see what happens to them, and then you record whether they ended up on infusion or not. If I would. Good question. If our audit department doesn't get back to us before the deadline/study window, could we retain data locally and then submit once approval has been granted? So that is very much a local decision. I would be reluctant to start gathering data and doing something locally if you don't have local approval. Obviously, the ideal situation is that you have local approval, but I cannot advocate you collecting data locally and doing things locally if you don't have local approval. So that is absolutely key. In terms of our pathways, we won't submit people REDCap logins if we've not seen your audit approval. There's an element of diligence around that, so we need to physically see your audit approval in the email. We've got a system where you can basically upload it to us, and then we'll pick that up and then be able to give you a REDCap login. I think that's all the questions in the chat. So I'm going to go back to the Q&A, see if there's any new ones in here, which there are. So this is a kind of follow on from the excluding patients who've over the 24-hour period. So what if we receive a patient on a neuromuscular blockade infusion from another hospital started within 24 hours? Do we continue data collection? How do we know that patient is in TRIC block?
So that patient would be included.
Yeah.
How you would be sure they're not double counted in TRIC block, I don't know. I'll have to have a think about that and get back to you. Yeah, I guess there would be no way of knowing. In reality, we just have to maybe accept that that patient gets double counted because we're never going to share data between sites or with us, so there wouldn't actually be a way of doing that. I guess the site they came from would hopefully mark them as transferred out, so at least that would end their data collection. So
yeah, I agree. So yeah, that patient would be collected. I think, Rich, maybe we should have a chat about how we detect that, because we could potentially put something in the CRF around, was this patient transferred in? How did they get in? We also don't want to be identifying the patients, but we could do something around that.
Yeah,
to reduce the risk of that, because there won't be many, and we could potentially do site queries to help answer that. HEMS quest. We see some patients intubated by HEMS as part of trauma, TBI, but then have nothing significant on their CT head. It does happen. What would you like us to put as indication for intubation?
Yeah, so good question. So in the all other patients subgroup, it then asks you the reason for intubation, and one of the options is trauma brackets not TBI, so you could choose that.
Yeah. Awesome. Anything back in the chat? If the trust doesn't register service evaluation, will the email from the Caldecott Guardian lead of the department work be enough to be included in the project? So again, it will be based on what your local audit policies are and what the view of your local department is, as well as Caldecott Guardian. Email us what you have from your Caldecott lead, and we can kind of cross that bridge if we get there. Our experience in the past is that, you know, we've had 150 sites in the past. Audit departments are generally pretty good and understand this stuff. I know sometimes it can be challenging, but if you've got it's unusual that the Caldecott Guardian and the audit department wouldn't be on the same page. But that's a kind of specific scenario, which by all means email us and we can have a look at that. Do we get data about our trust afterwards, which we enter in REDCap? So we are able to share site-specific data back with you. Ultimately, it's your site data, and many audit departments will have a requirement that you present audits and your data back. Bear with us, because sometimes that could be challenging when we've got 150 sites and we're trying to do that. I know we had that for TRIC Man, but we can do that. You obviously have to email us after the project. We won't be instant, we won't be able to do it in days, but we will get it to you, and ultimately it's your data and we can definitely feed that back. If they initially presented with TBI and then developed ARDS, which one would it be counted under?
Yeah, so you put TBI first, and then there will be a question in the TBI form which says, did the patient subsequently develop ARDS? So you can tick that, and then it will, you know, unfortunately for you, then you'll have two lots of forms to fill in. But yeah, there is a way to capture that. Yeah.
Lovely. I'm just loading up the Q&A. You know what? I think we might have covered them all, unless there's any others that are going to start coming in.
Brilliant. So I'll just say, you know, if anyone's having any difficulties with getting approval or sign off, if you get any concerns, please just talk to us early and tell us what's going on, because we can try and provide more explanation or clarification on points if needed. So we're very keen to work with you and get as many sites on board as possible. So yeah, just get in touch, send emails at the TRIC Block email, and someone will get back to you.
Yeah, absolutely. Yeah, I echo that, and I think over the last few years that we've been doing this, we've had, you know, lots of different local things that crop up, and we've usually either experienced it or we can find some form of way forward and get you involved. Obviously, the priority, I think, for site leads at the minute is going to be trying to work with your audit departments to get local approvals. And as I say, once we've got those local approvals, we can then start issuing your REDCap logins. And then locally, I think it's all about assembling a good team of people. We'll obviously need their details for the REDCap logins, and ultimately that will be the details that are used in future publications of collaborators. You want to have a decent team to make sure you're not going to miss any patients and share the workload. And then think carefully about when the best period is for your data collection window. It's deliberately baked in the design that you have some say of when that 2-week period is, just to make sure that it works well with your team. So start thinking about that. I don't think we've got any other questions. So we'll probably stay online for a few more minutes, see if anything comes in. But I don't think we've got any new information to share. So if people want to drop off the call, and enjoy their evening, please do, and we'll leave it there. But myself, Rich, and the rest of the committee will stick around for a few more minutes if anyone has any other questions. Thank you, everyone.
Thanks, everyone. Thank you so much.
Lots of thanks in the chat, Rich. Lots of thank yous. Thanks, everyone.
Very kind when everyone else is going to do all the work.
We've got a new question. What timeframes are likely for you sending out the form to submit the local audit approval and the subsequent form to submit collaborators for each site? We're pretty quick on the whole.
Yeah.
So yeah, there's a group of us that kind of staff the email box. So generally we're quite quick. We'll be busy over the next few weeks as we get snowed with lots of sites taking part, but yeah, we can generally turn it around pretty quickly. Yeah.
Just to check from your question, Ben, are you asking, have you had the initial email with the protocol and instruction for site leads, or are you missing that? You can probably, I don't know if your mic will work, but you could always write a comment under your question.
I might be able to unmute you, Ben. Hang on. Disable mic. No, allow mic. I don't know whether I can.
Well, if you're still there, Ben, I will send you an email. Oh, hang on.
No.
No. Yeah, I'll send him an email.
Probably. Cool. I am going to stop the recording if I can figure out how to do that. Yeah, stop. There we go. That'll do.